Previously, we looked at the normal adaptive inflammatory stress response. Sometimes that picture comes off the rails and the process becomes maladaptive. The body damages itself and the patient develops one of a variety of critical illness syndromes, in particular the syndrome we call sepsis. Before we get into that, I want to discuss what you do when the patient is at the height of the stress response. For example, when do you give resuscitation fluids? How much do you give and for how long?
Tutorial 7. Critical Illness and Resuscitation. Previously, we looked at the ebb and flow phase of the standard stress response. This is the normal inflammatory response that is fully adaptive and that we see in perioperative medicine and in standard injuries that are not prolonged. We looked at how the body retains fluid in stressed states, particularly salt and water, how resuscitation fluid redistributes when given intravenously, and then we looked at how to estimate using the classical approach perioperative fluid requirements. In this tutorial, we will look at the concept of third space fluid losses, what they are and what they are not, the stress response in critical illness, capillary leak syndrome, and the use of resuscitation fluids in critical care. Let's start with a clinical scenario. You're called to the emergency department to Hector. Now, Hector is a 57-year-old janitor, and he comes to the ED complaining of nausea, vomiting, and abdominal pain. Of note, Hector has a background history of Crohn's disease, and he has had multiple previous abdominal surgeries. And this is a big red flag. When we examine Hector, his heart rate is 120, his blood pressure is 80/60, his respiratory rate is 22, and his temperature is 35.5. These are all signs of a stress response, an inflammatory response. His abdomen is distended, it's tense, and it's tympanic to percussion. So there's a lot of gas trapped in there. A urinary catheter is placed and only 10 mils of urine comes out. On imaging, in a plain abdominal film, you can see these big distended bowel loops with fluid levels. So Hector has an acute abdominal emergency and he is now undergoing a stress response. This is the triphasic stress response, ebb, flow, and recovery that we previously discussed. This is where Hector is now, just at the beginning of his flow phase of the stress response, with really excellent care, management by surgeons and anesthesiologists and intensive care clinicians. He should follow a standard pathway where that burns itself out after about 72 hours, and then after a week the entire stress response has resolved. One of the problems that Hector has here is this. This is a cartoon of the gastrointestinal tract. You can see here the stomach, the liver, the small bowel, pancreas, large bowel, etc. And of course, we eat into our stomach, and when food goes along, we secrete all kinds of stuff into our gastrointestinal tract. We have bile, we have gastric juice, we have pancreatic juice, and along that pathway, nutrients are broken up and reabsorbed through the small bowel, and eventually in the large bowel there's pretty much only feces and water, and a lot of that water is stuff that's very rich in electrolytes, mind. It contains a lot of fluid that was previously secreted out of the body into the bowel. So and that water is reabsorbed through the splanchnic circulation back into the liver, and of course back into the circulation. So essentially there is this cycle of fluid that the body secretes and reabsorbs, plus the water that is derived from the food, and of course water that we drink ourselves. Now, in a situation like Hector's, he has probably an adhesion that is kinking a bit of the bowel. So here is a distal small bowel obstruction. And this is hugely problematic because what happens here initially is all of that bowel starts to fill up with liquid. Initially, the liquid that he is, of course, been eating and drinking as it's just developing, and then a lot of secretory stuff that goes into the bowel until all of that kind of switches itself off. And there can be quite a lot of liquid that is really rich in electrolytes such as sodium and potassium and chloride and bicarbonate, all trapped in there in the bowel. There's two issues here. First of all, fluids are not being reabsorbed, and these fluids are also being trapped in the bowel, and we call the trapped fluid third space fluid loss. It's in the body, but it's outside the body, so it's not available to the body. It's not in the intravascular space or the extracellular space or the intracellular space. It's in a third space. On top of this, of course, Hector is getting actively dehydrated because he can't drink. There's no way of getting liquid into his body. So he's had no fluid intake since his bowel obstruction. He's dehydrated and he's water depleted. And then, of course, he's all this loss of electrolyte-rich fluid that's been secreted into the upper intestinal tract. This whole process of third space fluid loss is seen with bowel obstruction, it's seen with pleural effusions, it's seen with pericardial effusions, rarely in that kind of huge volume. It's also seen with ascites, which can be astonishingly large in volume, 10 or 12 litres, and it can be seen in smaller amounts in joint effusions. But normally the major problem with third space fluid losses is realistically with bowel obstructions. What is the electrolyte content of this lost fluid? I said it's full of stuff. Well, if you actually look at the different fluids that are secreted by the gastrointestinal tract, there's gastric juice, about 120 millimoles or milliequivalents of sodium, 10 of potassium, 10 of chloride. There's no bicarbonate there. Bile has 140 of sodium, 5 of potassium, about 100 of chloride. The pancreatic juice has 140 of sodium, 5 of potassium, 75 of chloride, and a good load of bicarbonate, about 60 millimoles of bicarbonate. The small intestine, 120 of sodium, 5 of potassium, 105 of chloride. Diarrhea, which is the stuff that comes out of the large bowel, 120 of sodium, 15 of potassium, and 90 of chloride. Now these all look more or less the same, right? They're all, and these numbers are familiar because all of this looks a whole lot like extracellular fluid. And so in general, GI losses are of extracellular fluid, and that's a good thing to know. Depending on the duration of bowel obstruction, there is often a 4 to 7 litre fluid deficit. And so this patient will have a fluid deficit, third space fluid loss with extracellular fluid, so they need a resuscitation fluid. Now, there are other reasons for using isotonic fluids. Blood loss, because the patient loses plasma, which is extracellular fluid plus blood cells and albumin. Dehydration losses, and the patient, when they start sweating or they dehydrate, remember sweat contains a lot of sodium and chloride and water. Vomiting, where the patient loses lots of water, and they tend to lose a lot of chloride as well, plus bile. So it's mostly extracellular fluid, but there may be a surplus of chloride. And then of course diarrhea, where the patient loses extracellular fluid, and bowel obstruction. In the situation of someone who's just vomiting an awful lot, because they tend to lose a lot of chloride, really this is often one of the times where you might decide to give your patient isotonic saline solution to resuscitate them, because they do actually need a net load of chloride, because stomach contents contain hydrogen chloride. Of course, the hydrogen is a dissociation product of water. They have a net loss of chloride, and they may develop a hypochloremic metabolic alkalosis. We will visit this in detail later on in the course. And so you can give them isotonic saline solution. They'll often need some potassium as well, or just give them compound sodium lactate that also contains a slight surplus of chloride. Most of the time, when you have extracellular fluid loss, you need to give them a fluid that looks like extracellular fluid. And these are the balanced salt solutions that I mentioned in the last talk. These are sodium lactate solutions, Plasmolite, and normal salt. And this is what's in these fluids. And if you look very, very carefully at them, these are the different fluids here on the left-hand side. Isotonic saline, normal salt, Plasmolite, Hartmann solution, and lactated ringers. And then you look at the various different columns which shows what's in each one of them. The first column is a sodium, and virtually all of these fluids contain about 130 to 140 millimoles of sodium. Obviously, saline solution has a little bit more sodium in it. Secondly, they contain about 98 to 111 millimoles of chloride, again mirroring what's more or less in the extracellular fluid. Now, to have a shelf life, the difference in the charge between the sodium and the chloride, which is between 20 and 41, 42 milli equivalents, there has to be an anionic buffer in there, an electrolyte that contains a negative charge. Now, that negative charge is normally carried by albumin, phosphorus, and bicarbonate, but you can't make up an IV fluid with bicarbonate because it starts to bind with the other stuff and turns into kind of a chalky stuff. And so what you give is a pre-bicarbonate anionic buffer. These may be lactate, acetate, or gluconate. There's between 27 and 50 millimoles per liter of this stuff, and it's metabolized in the liver to carbon dioxide and water, which for all intents and purposes is bicarbonate. Most of the balanced fluids contain a small amount of potassium. Lactated Ringer's contains 4 millimoles per liter, Hartmann's 5 millimoles per liter, Normasol and Plasmolite 5 millimoles per liter. And there is a common fallacy, and I don't know how many times this has been said to me over the years. The Plasmolite, for example, has 5 millimoles per liter, and on the surface that seems like an awful lot of potassium. And I often hear this line, "Oh my God, do you really want to give Plasmolite? The patient's potassium is 5.3 millimoles per liter. Aren't you worried that the patient will become hyperkalemic and have a cardiac arrest?" amongst other disasters. Remember, the daily potassium requirement is 80 millimoles per liter. You would have to administer 16 liters of Plasmolite or compound sodium lactate, Hartmann's or lactated Ringer's, just to meet requirements. In fact, if you decide to use isotonic fluid as maintenance, you will inevitably see a rise in the sodium and the chloride and a fall in the potassium. Obviously, if the patient is in acute renal injury and they're anuric and they're acidotic, that is a different situation. But for the vast majority of patients, they're actually actively becoming depleted in potassium. But wait, there is more. You do need to be careful once you have your patient resuscitated about anything that you give them. And I've said this before, but I'm just going to remind you of this. Once the patient is resuscitated, if you feel you have to continue to give them intravenous fluids, you need to not be giving them these resuscitation fluids. They contain too much sodium, too much chloride. They don't contain enough potassium. There is insufficient magnesium, calcium, and phosphorus. And they don't contain glucose. The lactate will generate a few calories, but not enough. And as a consequence, the patient will become ketotic. And if they have a fatty liver, or they have type 2 diabetes, or they just can't handle ketones, they will develop ketoacidosis. So, returning to what we've previously said, an 80 kilogram patient will require about 120 mils per hour of maintenance. If there's a 4 to 6 litre deficit, such as Hector has here with his bowel obstruction, it's probably reasonable to give him a 250 mil per hour infusion. That will replete the losses gently over 36 hours. You don't want to be pouring that in a litre every hour. That will just frack the interstitial matrix and cause all kinds of damage. You just cannot give that fluid back that quickly. It's just not possible. It's not an exact science, and care must be taken when you're resuscitating a patient with crystalloid to avoid over-resuscitation. And once you're happy that that patient is adequately resuscitated, you must transition to hypotonic fluid as maintenance fluid once the solute has been restored. Hector goes to the operating room, and during intubation, feculent fluid is aspirated into Hector's lungs. While decompressing the small bowel obstruction, the abdomen becomes severely contaminated with bowel products, and then he returns to the ICU profoundly hypotension. Now, Hector is having a massive systemic inflammatory response. This will turn into septic shock as bacteria start to proliferate. Hector goes to the operating room to have a bowel resection. During intubation, the feculent fluid is aspirated into Hector's lungs, and while decompressing the small bowel obstruction, the abdomen becomes severely contaminated by bowel contents. Hector gets really sick in the operating room, And by the time he gets back to the ICU, he is profoundly hypotensive. So now Hector has a serious systemic inflammatory response to two separate major injuries that he's incurred during his operation. This will develop into septic shock. In severe injury or critical illness, the flow phase may be more extensive and or it may be slower to resolve. Going back to our picture from earlier on, we have on the y-axis the inflammatory response, and there is the injury, which is substantial. Because the Hector is under anesthesia, the flow phase starts right away. And you can see here the magnitude of that flow phase is much, much greater than we saw in the previous discussion about Mildred. He's having a huge inflammatory response. Now, that inflammatory response, or the flow phase, can go on for a long time. And that it's not just 48 or 72 hours, it can go on for a week, it can go on for 2 weeks. And then what happens is, as Hector's inflammatory tissue reserve starts to be used up and run out, and he ends up with no reserve left, he would end up in a dysfunctional flow phase where he is hypo-inflammatory, where everything kind of slows down and nothing seems to work terribly well. And we call this chronic critical illness. Now, if Hector is lucky, he will recover from this, and then he will have to generate an inflammatory response as part of his recovery. If we are to look at this acute critical illness in phases, the first phase here is a systemic inflammatory phase, the systemic inflammatory response syndrome, where you have this big flow phase. The second dysfunctional flow phase is a prolonged period of hypoinflammation where the patient just runs out of reserve. This is extremely difficult to manage. I believe it is the number one pressing problem in modern critical illness. If Hector is to recover, he needs to go back into an anabolic phase where his body starts to build protein and he generates an inflammatory response. His inflammatory reserve is restored. The single biggest mistake you can do with someone like Hector is decide that you can somehow or other rescue him by giving him large doses of corticosteroids during the hypoinflammatory stage or the recovery stage. That will just wipe out his ability to actually generate the inflammatory response that is needed to recover from critical illness. One of the major complications of acute critical illness is this concept known as capillary leak syndrome. It appears that during the hyperinflammatory response and, of course, the administration of large amounts of crystalloid as part of the flow phase where patients get quite hypotensive, the glycocalyx and the superstructure of the capillaries starts to break down and the capillaries become quite porous. Very little fluid normally extravasates out of the capillaries. But when the matrix is broken down, the interstitial matrix is broken down and the glycocalyx is disrupted, fluid literally pours out and the capillaries become really leaky, and then all this protein-rich exudate enters the interstitium and the body becomes quite edematous and the patient gains a lot of weight. Now, all kinds of adverse outcomes follow from this. Pulmonary edema, sometimes so bad the patient becomes profoundly hypoxemic, pleural effusions, and sometimes that will cause a thoracic compartment syndrome, myocardial ischemia, bowel edema that may cause malnutrition and ileus. At the worst, it can cause abdominal compartment syndrome, kidney dysfunction, you can get a renal compartment syndrome, liver dysfunction, coagulopathy, intracranial hypertension, etc., etc. This is not to be sniffed at. This can be a major problem. Patients can accumulate a staggering amount of fluid in critical illness. This patient starting off here at 80 kilograms can get up to maybe 90 kilograms during the dysfunctional flow phase, which is more than a 10% gain in body weight. This is not good, and they definitely need to be de-resuscitated back down at some stage to their normal weight. But that de-resuscitation can only start when the source is controlled and the patient has been stabilized. So if a patient, for example, like Hector, has this kind of intra-abdominal leak of contents going on despite having had surgery, he will continue to stay in that flow phase and sequester fluid continuously until that has been resolved. So until the source is being controlled, he will not give up that fluid and he cannot be de-resuscitated. Nevertheless, a lot of the time when patients develop this huge fluid overload, it's actually caused by carelessness by the critical care bedside staff, the doctors and the nurses, who are just not paying enough attention. And the reason for that, it's not just the intravenous fluids that the patient is accumulating, it's enteral feed, it's the drugs that are given for sedation, it's the fluids that are used to deliver antibiotics, it's the fluids that are used to replete electrolytes. And so as practitioners, we need to be constantly looking at fluid balance.
Remember the normal stress response to acute illness, where we had an ebb phase, a flow phase, and a recovery phase. And this all goes on over approximately a 72-hour period. The flow phase is about 48 hours, and then that recovery phase goes on for another day or so. And we see this in perioperative medicine in people with modest to moderate injuries. And this acute stress response is fully adaptive. It's supposed to happen. It's how we evolved. It's a mechanism that our body developed to keep us alive when we were injured. And it works really well most of the time and really successfully, and that's why we're still alive. In critical illness, the stress response is maladaptive. It is not supposed to happen this way. And we don't really know why that happens. We know sometimes sepsis, for example, is diagnosed late and antibiotics have been given late, and we have developed a severe form of exotoxic shock. Perhaps we've given the wrong antibiotics. Sometimes we have over-treated the patient in some way or other. Maybe there's a genetic abnormality. We don't know, but it is a maladaptive response. And what we see is this initial injury followed by this huge hyperinflammatory flow phase that may go on for quite some time until we really run out of inflammatory tissue, and then everything kind of slows down and the patient becomes hypoinflammatory. They stay catabolic. They keep breaking down protein and mobilizing it and using it for energy. But at some stage, the patient develops sufficient inflammatory reserve, and the source that is pushing along the stress response eventually resolves or is controlled, and the patient goes into a recovery phase and they become anabolic again, and they develop low-level inflammation, and eventually they get better. So the big question that has arisen for many years is this whole long flow phase. Is there anything we can do beyond initially giving antibiotics and treating the patient really well up front to kind of resolve this and stop it from happening and protect the patient in some way? Well, if you were going to do something, you need to do it right here at the very beginning of the flow phase. And it might well be that you might give an inflammatory modulating drug, an anti-inflammatory drug, or a drug that interferes with inflammatory pathways, for example, corticosteroids that really affect all aspects of inflammatory responses versus, for example, IL-6 inhibitors we might use at this stage to try and stop the patient having a massive pro-inflammatory response. What you absolutely do not want to be doing is giving these drugs here after the patient has used up all of their inflammatory reserve while they're now hypoinflammatory and the whole thing is burning itself out. At this stage, by giving a patient anti-inflammatory agents, you are interfering with tissue healing. You are preventing the patient redeveloping their inflammatory reserve, and you are
affecting negatively their ability to recover from critical illness. And what may actually happen in this setting, and it's not just necessary due to drugs being given in this setting, is instead of the patient having this nice upward swing in their inflammatory response and their metabolic activity, they go into a hypometabolic state where the neuroendocrine system and the autonomic nervous system burns itself out, and the patient ends up in this state of stasis where they're not getting better, they're not getting worse. But of course, if you're not getting better, you are getting worse. But they just seem to land in the bed in the ICU. They may not wean from mechanical ventilation. No, they don't need vasopressors. No, they may not need renal replacement therapy, but they just don't seem to get better. And for the majority of these patients with chronic critical illness, the outcome is usually death. And so it's really important to understand these different phases in the stress response, even the maladaptive stress response in critical illness, so that you make the right decisions at the right time. Let's review this tutorial. In this tutorial, I covered the stress response in critical illness, third space fluid loss, resuscitation fluids, capillary leak, and adaptive and maladaptive stress responses. Next time, I will discuss the distribution of blood in the body, circulation prime, blood loss and oxygen delivery, and transfusion therapy.
Okay, so that was resuscitation fluids, capillary leak, and the maladaptive stress response. These are things we encounter during critical illness. During the remainder of this course, we will revisit these concepts several times.